Welcome to AETCM YouTube channel. Today we will have a cardiology case discussion, and for this we have Dr. Jaydeep sir, Professor Department of Cardiology, Amrita. Over to you.
Thank you, sir. Sir, an elderly female was brought to ER. I got initial small history from my EMT staff that the patient is having right upper limb, lower limb weakness. So immediately I received the patient and I did my primary survey. In the initial 10-second assessment, patient was conscious oriented and she was able to completely respond to my questions. But mild dysarthria I have noted at that time itself. Then I went to my primary survey. In primary survey, airway is patent. She is maintaining a saturation of 99% in room air with a respiratory rate of 18 breaths per minute. Then I went to the circulation part. BP, she was having around 160 millimeters of mercury. With the pulse rate, I have noted that it is hardly around 46 in the right radial artery, and I cross-checked in the other areas also.
Was it regular? The pulse?
Yes, it was regular, sir. But it was hardly around between 45 and 50, sir. So immediately I connected her to the chest leads. And the monitor, it was showing a sinus bradycardia. But currently I didn't intervene because she was conscious oriented and she was hemodynamically stable. Anyway, then I proceeded with, but no other palpitation. She was asymptomatic at that time. So then I went to the pulse rate, BP, everything was stable.
BP, what was it?
BP was 160 millimeters of mercury, sir. Then I went to the disability part. Disability, GCS was 15/15, pupils were 2.5 mm bilaterally reactive, and GRBS also I checked at that time. GRBS was around 180 milligrams per deciliter was there.
No previous history of diabetes, no coma.
Actually, sir, we comes to the history at the second part, but right now we'll say that she's not on any medications, or she, as if her to her knowledge or bystanders, she doesn't have any coma. Okay. She's from a hill station, from a rural area, sir. I mean, I don't think she's having very good medical facilities. Then I went to the exposure part. The peripheries were warm, and anyway gave a blanket to cover her. Then I reassessed the primary survey. In the reassessment, again the airway is patent, breathing is patent. Breathing I missed her. Breathing air entry was bilaterally equal, and S1 S2 was audible, but bradycardia was we were able to see that it's having bradycardia. Heart rate was low. And but air entry was equal, chest rise, everything was fine, sir. Then circulation, again I cross-checked the pulse rate. Still it is maintaining around 40, between 45 and 50, but hemodynamically stable, conscious oriented, and pulse was still regular and having a sinus bradycardia. Then the reassessed the primary survey, she is maintaining the fine. So as an adjunct to the primary survey, I asked for a total ECG, and I took an VBG just to make sure for electrolytes. I don't want to know the acid-base status as if now, but I just to, in our ABG we have other parameters like point of care electrolytes like sodium, potassium, everything we can, lactate, everything we can immediately know. Then this patient, we did the BBG, and the electrolytes were found to be within normal limit with a normal lactate range, sir. So as an adjunct, I asked only that at that point in time.
What are the electrolytes you are worried about?
Electrolytes are bradycardia. One thing is we have to make sure of hyperkalemia. Maybe hyperkalemia induced bradycardia will be there. Bilirubin should be there. Bilirubin can cause sinus dysfunction. Then other parameters like we should look for any
electrolytes specifically. Anything else?
Phosphorus, sodium, potassium, calcium also is there.
Sodium, potassium, sodium, phosphorus. You are not worried
about bradycardia.
Calcium, magnesium, and potassium.
Potassium. When calcium, you will get only ionized calcium in the ABG. We won't get the total calcium. Then I went to the secondary survey, sir. In secondary survey, signs and symptoms first we used to examine. For a detailed examination, I noted that she is having dysarthria, but no obvious deviation of angle of mouth was there. Right upper limb around 3 to 4/5 power was there in the right upper limb and lower limb also. But right lower limb was an extensor, but left upper limb, lower limb, entire 5/5 power was there. Deep tendon reflexes were present. Superficial reflexes were also within present. Cranial nerves also within normal limit, especially 9-10. We cross-checked, it's normal. Then I went to the sample history. No history of any allergies in the past, no history of any medications in the past. Then last meal was in the morning before she developed the symptoms. Then I went to the even why she was came to the hospital. She was an apparently normal patient with no comorbidities or not on any medications, but she has developed an episode of syncope on the day before the day of presentation to our ER, following which she was taken to a local hospital where only physician is available. He checked the BP. BP was found to be on higher side. He said probably because of that, because she became asymptomatic at that hospital, and he was given some antihypertensive when she was discharged to home when she was fine. Next day morning, the bystanders noted that she is having dysarthria, and she is now having.
So what was the symptoms she presented? Just syncope. No
just syncope.
residual-
No. At that time there was no weakness or nothing was there. Only one episode of syncope was there. That too, they are not sure that the based on that bystanders, she was having little unresponsive, but when they stimulated, she actually came to stimulus.
Any record of heart rate or
No,
ECG
nothing,
there?
sir, nothing done. So nothing done. So next day morning, she developed. They noted that right upper limb. She was complaining that she is having heaviness in moving the right upper limb, lower limb. Following which, they immediately brought the patient to Ahmedabad, sir. That's even why she came to our hospital. Then I went to the head to foot examination. Head appears normal.
So she woke up with that symptoms. That's what you told.
No, they are not saying as if woke up. The next day morning she was not noticing. She was eating food and all. Then bystanders noticed dysarthria. When they asked whether she is having any other symptoms, she is saying that then only when they were asked only she is saying that she is finding some difficulty in moving right upper limb, lower limb.
Is the time of onset important?
Sir, time of onset is whenever in a CVA comes, the thrombolysis to be done or not has to be done, whether the patient is in window period or not. But this happened in the morning. This patient came around 6:30 evening in the evening. She was definitely out of window period. So we didn't immediately go ahead with the CT imaging. We later patient was planned for an MRI.
We'll just have a discussion now, and then we'll go to the imaging studies.
Yes, sir.
So what were your thought processes, Riaz? So here you have a 72-year-old, a lady, apparently normal till then. What you've got as a positive finding is that she's got right-sided hemiplegia, plus minus dysarthria, and you've noticed a bradycardia. And the bradycardia is with a hypotension, though she had hypertension which was recorded at the place of where she'd first call of hospital. So two ways to look at it. You want to know the chicken or the egg, whether the bradycardia is what is actually led to the stroke, or whether the stroke is actually leading to a bradycardia. If somebody has a very dense hemiplegia, or you get posterior cerebral territory, that is, in a close where the CSF pressure is likely to be high, you get bradycardia secondary to this.
Cushing's reflex is a possibility.
So that is something that you have to keep in mind. But what goes against the Cushing's is
other than that, there is no hypertension, no altered respiratory.
There is no hypertension.
No raised ICT, other features, vomiting, nothing was
So
noted,
from what
sir.
you say, it's actually unlikely, but that's something that you've got to keep in mind.
But we have to keep it in mind.
And then the other way around, whether it's a bradycardia that's actually pushed her towards this, which actually sounds more likely from the history.
Sir.
When somebody gets up in the morning with a stroke, it almost always is a cardioembolic stroke. So, one would have to, your reasoning should be that way, whether it's some primary cardiac ailment or rhythm disturbance that actually pushed the lady towards a stroke.
Yes, sir.
Okay.
Then I went to head to foot examination. They must central nervous system everything within normal limit. Examined the dysarthria, no obvious deviation of angle of mouth. The motor system, the power was deficit on the right side, and the sensory system, but everything was intact, sir. She was able to appreciate all sensation, all part of the body. And then other than that, cardiovascular system, we were able to auscultate the S1, S2, and JVP was within normal limit, and the pulse rate and BP was still holding to be in the normal range, and the bradycardia persists. And otherwise, respiratory system, chest air entry was bilaterally equal, no added sounds were noted, and chest rise, everything was within normal limits, sir. So that was a brief head to foot examination, everything was normal. So I came to the provisional diagnosis that the patient is having a possible acute CVA and bradycardia to be evaluated. Bradycardia under evaluation was the initial diagnosis. So I sent for the routine blood investigation, include thyroid function test was sent for. Other than when I sent for a set of cardiac enzymes were also sent, sir. And I planned for, I discussed with the bystanders, and I planned for that the patient is to be done, an MRI has to be done to rule out any weekend salvageable penumbra, anything is there, and patient can be taken up for any thrombolysis. As per the new guidelines, we proceeded with an MRI. So in our hospital, we have the MRI stroke protocol in which we can detect any salvageable penumbra is there or not. So MRI stroke protocol was planned for this patient, and I explained to the bystanders that the patient is in the bradycardia. If she develops any kind of signs of hemodynamic instability or anything, we will have to proceed with immediate pacing and all. I explained to the bystanders everything, and I shifted him for the MRI stroke protocol. And MRI stroke protocol is showing patient was showing No, you can say. See, left posterior circulation and MCA territory and infarct was there. In the areas are left gangliocapsular region and left temporooccipital region. Hypotensive lesions were noted. So let's say
Left gangliocapsular
and the left temporooccipital region.
Okay.
Acute infarct was noted, sir, and she was brought to the ER back. But in ER, suddenly she developed an episode of syncope, sir. The patient became unresponsive. So again, immediately I did my primary, sir.
lying down?
No.
The patient was in the trolley, sir. Patient was completely all the time in the trolley. We never allowed him to. She was completely shifted and brought back everything in trolley. She was lying in the trolley only. She came back and we received the patient in the ER and in the bed only. When we tried to went and tried to explain everything only. Actually at that time the stroke on call, everything came. At that time only when we were discussing only, she developed an episode of syncope.
Do you want to describe what happened? What you are calling as syncope?
She became unresponsive, sir. She became unresponsive, and even with the stimulus she didn't respond. But after some time, she actually at that time immediately we connected to the pacemaker and all. To the chest leads, cardiac monitors, chest leads, everything were connected. Again, right now it is having bradycardia around 41, 42, but this time it was symptomatic bradycardia. It was working more like a complete heart block. So immediately I took again a complete ECG, sir. So this time it was in a complete heart block. The RR, P and R, there is no correlation. RR intervals remaining same, PP interval remaining same. So it was now it is compared to old ECG, it was in sinus brady, but this time it was in complete heart block, sir. So
and was the pulse palpable at that time?
Actually, no. The radial pulse this time it was not palpable, sir. Only monitor, pulse oximeter was also not picking up. Only in the monitor it was showing the heart rate of around 41, wide complex heart rate was monitored. So
was there incontinence of urine or?
No, nothing. It doesn't look like seizure because we doctors were at present at that time. It was not at all presenting like a seizure, sir.
No, not necessarily. Even if you have an asystole, you might have that.
Yes, sir. Understood.
The relaxation of the sphincters is basically due to acidosis due to any cause.
Yes.
So it's it doesn't mean that it's cardiac, nor does it say that it's not cardiac.
So immediately we tried a shot of atropine, but actually the heart rate didn't improve, sir. Then immediately we proceeded with the transcutaneous pacing. We already had the pacing monitor was there. Immediately a consent was taken from the bystanders. We gave since already BP was not at all recordable at that time, so we didn't give high shot of fentanyl. A small shot of 25 micro fentanyl for analgesic purpose was given. Immediately we placed the paddle, sir. We placed the paddle in the right sternum and the apex part. We used that paddle only. With that we immediately started the pacing after giving fentanyl. We started then a heart rate of around 60 was placed initially. Amplitude we actually calculate by 1 milliamperes per kg. So around she was around 65-70 kg. We started with 70 and the rate was 60, but we were not able to get the capture beat. So we increased up to 80 milliamperes. With the 80 milliamperes we started getting the capture beat. The peripheral pulses started improving, sir. Actually in meanwhile itself the patient sensorium started regaining, sir. Even though before actually completing our process, but
you'd not given a CPR or anything?
No, nothing. We didn't have to go because monitor was still having this, and central pulse we were able to get. Only peripheral pulse we lost. So we didn't start. So with this everything was already ready, so we were able to do it very quickly, and peripheral pulse also improved.
How many doses and what was the dose of how many times and what was the dose of atropine given?
Atropine 1 shot 6 was given, sir. 0.6. Then the thing is that since we usually know that complete heart block won't respond much to atropine, we immediately planned for pacing, sir. So immediately did the pacing. Usually in morbid type 2 and complete heart block, the atropine effect is usually we don't get much, sir. So
no, that's debatable. What you're supposed to do is to give atropine.
Yeah, we tried, sir. 1 shot we gave. We didn't go for multiple shots. 1 shot we gave, but it was not improving the heart rate. So we immediately went for pacing, and so we did the pacing, and after that her peripheral pulse everything improved, BP improved, and she was conscious and she was tolerating it, and we immediately informed the cardiology also, and we already the patient stroke team everything was there. So probable we assumed that with the transcutaneous pacing she was holding the BP pulse rate and she is conscious oriented, hemodynamic disorder. We explained to the bystanders that the patient will require temporary pacemaker insertion and she will have to be shifted to CCU, and she is having underlying stroke also. And right now we didn't load her on antiplatelet. Stroke people said that after pacing only we will decide. They said they will decide among themselves to whether we have to load with antiplatelets and all. So in the ED we didn't load the patient with the antiplatelets as per their request. So anticoagulation nothing was done. So patient BP once BP patients once the shiftable from BP pulse rate everything was in the recordable range. We shifted the patient to the CCU. In CCU they did a transfemoral femoral temporary pacemaking was done by that time, and she was stable. And next day and following which they actually started on dual antiplatelets. Anticoagulants were not started. Next day they proceeded with the permanent pacemaker insertion, sir, and she was later discharged with she was fine, and patient was fine, and later discharged with dual antiplatelets, and she was possible, and echo and CAG was done during the time of admission, and CAG was showing only mild coronary artery disease. LMCA, left circumflex, LAD was normal. LAD was showing 30% and CNOH, RCM mild plaquing. That was the CAG finding. And echo was also done. Echo was showing concentric LVH was there with a mild global LV, but no clots were detected in the echo. And later she was discharged with an apixaban was started, and apixaban 2.5 mg BD was planned to be started after 1 week of discharge from the hospital, and other routine and she was in the investigations that we have sent, only positive findings were that she was having urinary tract infection and also dyslipidemia with a total cholesterol of more than 220. And so she was discharged with dual antiplatelets along with and later she was found to have hypertension. I mean, always her BP was on the higher side. So she was started on a silacar 10 mg BD and a telmostatin 40 mg OD along with atorvastatin and metformin. She was discharged, sir.
I think we'll come back to the management once more. Like, assuming that we didn't have pacing facilities, how would you have proceeded in this case?
Pacing facilities not available means then we will have to repeat shots of atropine. We'll have to try, sir. And if pacing is not available, then only option is that we'll have to try transjugular pacing. Also, usually we don't do we better flow.
Yes, the ideal thing is of course pacing only.
Pacing only.
So in centers which do not have facility for pacing, is there any alternative or?
What other drugs can one give? See, you want to kickstart the heart, right?
Yes, sir.
So what else can you give? Any beta 1 stimulant that you can think of? Dopamine can be given, but it's not conventionally given for this, because that again depends on the BP. See, most of the times when somebody comes in complete heart block, the blood pressure tends to be very high, very wide pulse pressure. You'll get typically 190 by 60 or 200 by 70. So that itself makes dopamine a little difficult. Any other medicine that you usually give? Isoprenaline is what is usually given. That's 2 to 20 microgram. It's no kg per minute. It's you start with 2 microgram per minute and work your way up to 20 micrograms. Doesn't respond to that, it's very unlikely that it will respond. Dopamine acts more on the dopaminergic receptors. It's nothing to do on the adrenergic receptors. So the other options are to give NORAD, or which actually kickstart, which can actually increase the heart rate, but the flip side is again the blood pressure is what actually bothers us. So isoprenaline is much more safer in that aspect, in the sense it doesn't really do anything much on the BP. So, you know, discussion wise, from what you put together, it looks like this is a typical history of a complete heart block.
Yes, sir.
You know, somebody comes, you take an ECG, it shows a bradycardia. You do a Holter test, it will show that there are these intermittent runs of complete heart block. And symptoms also tend not to be very regular. It's there now, it's not there for a few weeks, again comes back on. It always is an issue, because one of the most challenging diagnoses to make is for syncope, because there are a whole series of tests to be done, and most of the times they draw a blank because they tend to come on once in a while.
Nice.
So that way it becomes a little challenging. But somebody who comes with a centennial event, in this case this is a stroke with a bradycardia, and you think that is a symptomatic bradycardia, that in itself is actually an indication for a pacemaker. So subsequent to having been admitted here, after the MRI, she goes into a complete heart block. So why did you say, what are the different types? You know, when you say complete heart block, what you mean is the atria and the ventricles are actually dissociated from each other.
Yes, sir.
Each one is working in parallel, it's not in series. So how does it affect us? I mean, what is the issue with complete heart block? So what, as long as the heart is beating 40 times a minute, isn't that enough?
It's not. It will be one thing is that the pumping will be in the opposite action, sir. When the atria contracts, ventricular contraction might simultaneously happen, and Major thing is that syncope is a major issue, sir.
No. See, syncope is the end result of blood not reaching the brain, right? So it tells you that the blood is not reaching the brain. So why does that occur is, if you go back to your physiology, okay, it's 60, 30 and 10. 60% of the blood flow actually occurs during diastole, and 30% is actually contribute early filling phase, and 30% is actually what is contributed by the atrial kick.
Yes.
Okay. So in atrial fibrillation, or just like in complete heart block, when they don't act in tandem,
simultaneously,
so that amount of blood that should have actually come into the left ventricle doesn't come in. So let's put it this way: why does one have a very high blood pressure with complete heart block? Usually the blood pressure is high because the heart is able to fill much better. So the Frank Starling kicks in. Or let's put it this way: suppose why does somebody become breathless during tachycardia is, normally at a heart rate of 0.72, you have of 72 beats per minute, you have a cardiac cycle of about 0.8 seconds. 0.5 would be in diastole, 0.3 would be in systole, approximately. So systole being an active process, it cannot shorten. So when the heart rate goes to about 120, what happens? The cardiac cycle becomes much shorter. So once it's about 0.5 seconds, what happens is the systole remains at 0.25 or so. Diastole also becomes 0.25. So the heart doesn't get enough of time to fill up, which is why the
lung
congestion, momentary congestion in the lungs is actually what you feel as breathlessness. So similarly, when you have a complete heart block and when you have a heart rate of only 30 or 35, you have a very prolonged period of diastole in which the filling of the heart, left ventricle especially, is much better than otherwise. So that is when there's a stretch, the contraction is better, so the systolic blood pressure goes up. Why does the diastole come down? Because the peripheries are very much relaxed secondary to the bradycardia itself. That is again under reflex. Okay, so in a complete heart block, you usually get it this way. Now suppose I were to ask you an MBBS question of what are the clinical signs that you would get with a complete heart block. Can you tell us? One, you told me that the rate is 40. What else? Okay. Can you diagnose complete heart block looking at a patient, looking at an individual? You would have heard, so it's something called a Cannon wave.
The large JVP will be having a significant A wave.
A wave. Why does that occur?
This atrial contraction against a closed mitral valve. Closed right side valves.
The tricuspid valve is closed. So when the right atrium pumps, the blood has no way to go out, it comes back up. So that's what you see as a Cannon wave. So different ways. You have an isorhythmic AV dissociation. Isorhythmic is the atria and the ventricles are in the same rate, but it is absolutely dissociated. But that's a very uncommon sort of presentation that you get. So usually, the suspicion of complete heart block comes with this wide pulse pressure, bradycardia, and the Cannon waves that you get. Anything else you can get? Can you get any murmurs in complete heart block?
Not sure.
You do, because just what I told you, because of the filling of the heart, you can get this mid-diastolic murmurs and flow murmurs just because of prolonged diastole. But that's not important. Different names given to this, which is actually irrelevant. So clinical examination, that's about it. And what else? How would you proceed when you say a pacemaker? Here, the challenge really is in when somebody comes with a stroke and you put a temporary pacemaker in. Remember, this is a venous axis. Yes. So veins anywhere are very compressible, right? So once you put in through the femoral or the transjugular route, it just needs some mild compression to stem the bleed. Somebody comes with a stroke, there's no question. Antiplatelets have to be given. The first thing first, patient comes, you have to pop a couple of pills, provided you know that his or her deglutition reflexes are okay and she's able to swallow. The rest of it comes later. Now when you put a permanent pacemaker, the permanent pacemaker is usually taken from a left-sided axis. Subclavian vein is what is usually used. So the challenge there is, because the artery and vein lie in so close proximity to each other, if you inadvertently puncture the subclavian artery, you can bleed torrentially inside. Number two challenge is, many a times when we try, you may actually prick the pleura. What we do is we direct the needle towards the junction of the first rib and the clavicle, and before that we do a cine of the vessel to know where the vein is, and we do it under fluoroscopic guidance. But what the fluoroscopy doesn't tell you is where the pleura is, where the artery is. You're looking at only the vein. So if you inadvertently, the two risks that we have with doing something on oral anticoagulants is, in case you puncture the artery or in case you puncture the pleura, which would require an ICD, then the likelihood of bleed is fairly significant, especially when you give a factor 10A or warfarin or anything, because very fairly long half-lives for all of them. What we generally do is dual antiplatelets. We continue with aspirin. We stop the clopidogrel for a few days prior to an elective procedure, but here this is an emergency. So we take the risks as they come, and you're just a little more careful in doing things. Usually nothing happens. Now that is one aspect. That like I said before, since it's a mainstem artery occlusion, the likelihood of a cardioembolic stroke is very high. Especially somebody getting up in the morning and discovering that he's not able to move his or her arms or legs, that again would suggest that. Then the third thing is about complete heart block. So what is complete heart block and what is AV dissociation? Can you, Riaz, you know?
Yes, sir. Complete heart block means the atrium and ventricles are contracting independently. Usually in the ECG it manifests that we will be able to detect P waves as well as QRS, and there will be probably white QRS. And the thing is that there won't be any relation between P, and P won't be followed by QRS. There will be a regular interval of P within a specific rate of P waves, and QRS will be having a definite interval. At a definite interval, QRS will be arriving. So usually in ECG we will be finding that there won't be any relation between P and QRS, but the PP interval will remain same. The QRS RR interval will be same. So usually, and the patient will be in the ventricular, patient's pulse rate will be in the ventricular rates. So that's how usually we identify the complete heart blocks.
This you have AV dissociation itself is divided into three: first degree, second degree, and third degree. Third degree is what you describe as complete heart block. So usually you have a sinus node, which is the dominant pacemaker, which kicks at 70, 60 to 100 per beat. So if that is dysfunctional or that's not working as well as it should, the lower pacemakers take over. So if the SA node is dysfunctional, the AV node takes over. So AV node usually beats at between about 30 to 55. So normal rates are about 45 and all is when you get the nodal rhythm. Even that is dysfunctional. It's then that you get an idioventricular rhythm. When we say idioventricular rhythm, the rhythm is not from the muscles, it's from the His-Purkinje system. So that is usually between 20 and 35. So how you make it out is, you look at the QRS width. In a nodoventricular, in a ventricular rhythm, it is a wide and broadened QRSs that you see, whereas in a nodal rhythm, it usually is not that broad. It may not be absolutely narrow, but it will be slightly broad, but nowhere near a ventricular rhythm. Just like when you see a ventricular ectopic, it's as broad as that is when you get idioventricular rhythm. So that's how it is. An idioventricular rhythm is good enough for maintaining life. The blood pressure and all, in most cases, is usually normal, unless there is some other issue in hand, in the sense that you have severe LV dysfunction or some other concomitant cardiac illness, which is what affects the patient more than the rhythm per se. Now, when you look at the causes that come to mind, it all again is dependent on age. So if somebody comes with 72 years, what you all discussed already, potassium is the thing that comes to mind first. One, look at the HB, creatinine, ESR and potassium, because if this is so, it is related to renal failure, and that's the treatment that should be given. And even if it's renal failure related to hyperkalemia, it's actually correctable in the sense that you just need a temporary pacemaker. And when you put in a temporary pacemaker lead in a patient with hyperkalemia, you've got to be very careful, because inevitably you trigger off a ventricular tachycardia or even a VFib. So one has to be a little careful given this milieu in hyperkalemia. So when you pace a pacemaker lead, see, what I'm trying to tell you is whether it's hyperkalemia or whatever, if you have a symptomatic bradycardia or complete heart block, a temporary pacemaker has to be put in. So whether the temporary has to be converted into a permanent pacemaker is a question. If it is related to electrolyte imbalance or renal failure, that is what is taken care of. You don't, you can remove the temporary after you correct the electrolytes and once the rhythm comes back to normal. So the other conditions that come to mind, can you just name a few? I mean, what else are the usual causes of complete heart block or AV dissociation?
Sir, any toxicity is a possibility, for example,
Like?
digoxin toxicity, complete.
What toxicity?
Digoxin.
Digoxin, okay.
Toxicity, or any beta blocker toxicity is a possibility. Then other causes that an acute MI can cause, any MI can cause a complete heart block.
Wait up in 5 minutes.
Complete heart block can be due to post-MI sequelae, it can be there. And other causes like odolum poisoning can cause heart block. Then any
see,
Science.
when you say 72-year-old, it's most likely
Science
related to degeneration itself. The AV node lies very close to the valvular structures, that the aortic and the mitral valves.
Yes, sir.
So with age, you always notice a small systolic murmur, right?
Yes, sir.
So that's usually related to sclerotic changes in the valve, which also almost inevitably those valves are calcified. So that calcium actually extends to the node.
Yes.
So that may be a reason. So a very common association with older ages is an aortic stenosis, degenerative aortic stenosis with this. Then you have other fibrocalciferous degenerative, many syndromes that are named that way. One other important cause that you would have to look at in the younger ages, not at 70, is the depository diseases, like whether it be sarcoid, whether it be hemochromatosis, whether it be amyloidosis. Many of them actually present with either atrial arrhythmias or they may come present with complete heart block. Somehow the deposition tends to be in the interventricular septum much more than the lateral walls, and that's why the node actually gets affected. So these are the basic mental checklists that you go through. It doesn't mean,
Pardon, sir?
COVID was negative?
Yes.
it doesn't mean that you do a workup for hemochromatosis or amyloidosis in every patient, but you'll have to keep these conditions in mind when somebody comes with complete heart block. And I think we'll wrap up with just telling about the different types of complete heart block. First degree is when you have a prolonged PR interval.
Usually patients are asymptomatic. Second degree, again, two types, Mobitz type 1 and type 2. Mobitz type 1 will be that the PR interval will be, if each P wave, the PR interval will be progressively prolonging, followed by a skip. It will be a P wave won't be followed by QRS, then again it picks up to normal PR interval, then gradually it will be increasing. Then Mobitz type 2 is like the PR interval will be remaining same, but all of a sudden one P wave won't be followed by QRS. There will be skipping there. And number type 3 is that complete heart block.
So which one of these are the most dangerous ones? Mobitz type
2 and complete heart block are
complete heart block. Even Mobitz type 1 may, even in a normal sleep, in somebody who's very athletic like this gentleman here, you might have this type Wenke backing. So it's just that suggests that there's a vagotonia. That's the vagal stimulation is much more significant than normal. And when you alluded to a myocardial infarction, one other important point is if people come with a complete heart block, it occurs in two situations. One is with an anterior wall MI, otherwise it may be with an inferior wall MI.
Right,
so the mechanisms for both are actually different. Inferior wall MI, because it's the inferior surface of the heart which rests on the diaphragm, which is richly innervated with vagal receptors. So the inferior surface is, there's a bradycardia due to two reasons. One is the AV nodal artery, which supplies the AV node, is a branch of the posterior descending artery, which almost always is a branch of the right coronary artery. So you call it the dominant artery. So one is because of ischemia there. The number two is because of the vagal receptors on the diaphragm where the inferior, which is what the inferior heart wall of the heart is. So that stimulation again can give rise to bradycardia. This is usually transient, which doesn't last for too long. Once the patient improves, the bradycardia actually improves. Where the other situation that it occurs is in an anterior wall MI. If you have an anterior wall MI with complete heart block, the prognosis is exceedingly poor. Why so? It just tells you that the heart, a large area of the heart is involved. So even whatever treatment you do, whether a primary PCI or whether it be an thrombolysis, the benefits is poor.
Right, sir. No more questions.
Yeah.
Okay, yes. Thanks a lot. Thanks, sir.
Thank you.
Thank you.